Thanks again for joining. I just wanted to start by introducing the faculty that we have today. So we've got Dr. Verna Vanderpuye, who's a clinical oncologist at the Kalalu Hospital in Accra, Ghana. We've got Michelle Tregear, who's a patient advocate and chief programs officer at the National Breast Cancer Coalition in the US. We have Dario Trapani, who's a medical oncologist at the University of Milan in Italy, and then myself, Brooke Wilson, medical oncologist here in Kingston, Canada. So thank you again for joining. So we're going to kick off just by giving a bit of an overview of CSO. I think there may be some people joining today who are less familiar with the organization. So we'll just spend a few minutes speaking about where the origins of CSO really came from, and I'll hand over to Dario to do this section.
So thanks, Brooke, and thanks to everybody for joining today. We really want to introduce just a little bit and quickly about the Common Sense Oncology movement and understand why we're here and what we want to do in the next future. In particular, the common sense really is rooted in this cancer medicine's paradox that is, the way in which the world of oncology is shaped today. In one part, there is, of course, medicines that are overutilized in the oncology for the cancer treatments, pretending just marginal benefit to the patients, but also adding more toxicity and sometimes with a trade-off that's not very favorable for the patients. And from the other side, of course, there is the big problem of the access to the high-value medicines, because if one part of the world has really access to everything, but with not kind of a good selection of the drugs, of course, there is another part of the world in which this kind of access to medicines is very puzzling, and of course, is very dismal. Next slide. So the paradox itself is embedded within the broader cancer values crisis, for which the way the oncology works nowadays and the landscape is shaped, it may be very problematic. In particular, we've identified problems in the way the clinical trials are designed and are communicated, in particular for the results, presenting many pitfalls that may some way mislead or magnify and hype the results of the clinical trial results. Also, we have many problems for the way in which we communicate and we test the new drugs, in particular in the terms of endpoints utilized, they may be very dubious, and also the type of effect size that is emphasized and reported as a benefit or a success for the clinical trial results. Sometimes it's just very small, and it's very unclear in what magnitude this is clinically meaningful. Of course, together with the staggering prices of cancer medicines and a problem in which we communicate and hype some of the results. Next slide. In general, the cure landscape of the oncology is also shaped in the way the cancer research and in particular the clinical trials are founded. And you see that in the last decades, the clinical trials are mostly founded by the industry with a little bit of change and a switch in the oncology business, the way oncology clinical trials are shaped and founded, and who is really the playing actor establishing the new paradigms. And in particular, you see that as the industry funding has increased in the recent years, also the utilization of the endpoints to prove the success of the clinical interventions and so the new drugs has of course changed, switching from overall survival that was more usually utilized by collaborative and academic clinical trials groups toward surrogate endpoints, in particular in the advanced setting, progression-free survival, as industry finding, of course, has increased. Next slide. So the opportunity and also the chance, because PFS occurred and happened in the design and happened as a primary endpoint of many clinical trials, randomized clinical trials nowadays, is really because it presents, some obvious benefit. In particular, PFS can be easily reproduced, can be easily measured. It's quicker to be collected, and also you fast track the drug development when you want to prove if a drug works or not, according to some efficacy endpoints. And in particular, there was an idea in the past that, of course, PFS, because it really displays the responses to the cancer treatments of the tumor itself, it should be able to predict overall survival and quality of life. But at this point, this kind of correlation is usually not reported, and we know that PFS is not necessarily a validated endpoint to prove that. So all the assumptions for which the PFS moved in randomized clinical trials nowadays, in fact, are really being revised. And now we know it's definitely imperfect because we have many periods to include PFS as a primary endpoint. Next slide. In particular, ignoring overall survival means exposing patients to many risks. You can have PFS benefits without any overall survival benefit. And in this case, you only provide some interventions that does really change the natural history of the disease, the trajectory, and patients are just getting toxicity, including types of toxicity, financial toxicity, and actual clinical toxicity. And also some of the drugs that actually have improved PFS in clinical trials, they demonstrated eventually to reduce overall survival, providing a detriment to the patient's outcomes. And at this point, this is something that we should avoid, of course, in the clinical research, because this is, like a false improvement of the benefit, but in fact, this is just a detriment for them. And then also some drugs, they don't really improve progression-free survival in an extent, but they can definitely improve overall survival in a larger extent, as it has happened in the past with many immunotherapy clinical trials. And so in these, the PFS is definitely imperfect to capture what is relevant for patients. Next slide. Overall, the landscape is really characterized by, like as taken together collectively by small improvement of the progression-free survival and overall survival. We know that at this point, the overall median improvement of progression-free survival across the last 2 decades of clinical trial results and drug approval is around 3 months of PFS increase. That is definitely small. Of course, there are differences. Some drugs are definitely portending more benefit, but this should be definitely balanced with some important patient-centric outcomes, in particular how toxicity is experienced and how this pervade, it really influence financial toxicity, time toxicity, especially close to the end of life. Next slide. So we did learn, the common sense oncology based on these presumption, and in particular, taking a look to the landscape, because of course we really want to make sure that the clinical trial design, the communication about the clinical trials, and overall of the cancer interventions and cancer planning in the health system is patient-centric and is really informed by patients' needs and not only by some metrics or something that is very imperfect, as so far it seems to have occurred in the clinical trial landscape. We really have a strong belief that the patients deserve better. We really want not to stay silent about the problem and want to vocalize how to improve according to the patient inputs and preference, how we can definitely change the landscape in a more patient-centric outcome. Next one. We, initially collected our initially thoughts and recommendations and reflections in an editorial that appeared on the Lancet Oncology that is now our documents for the main communication and that you can find online, including in the Common Sense Oncology website, in which we established and we communicated our mission and our visions. In particular, the mission of Common Sense Oncology is to ensure the cancer care focuses on the outcome that matter for patients, that the cancer care is planned and shaped in a patient-centric manner with the visions that patients should have access to the high-value treatments that provide clinically meaningful and patient-centric outcomes to them and not really any benefit, small benefits, or just based on surrogate endpoints. Next slide. And overall, the CSO is, of course, shaped through different initiatives and working group. And together we are here as part of the education working group to show how we can present some data from clinical trials and how we can articulate a discussion around clinical trial results. And I would like to give back to Brooke, of course, to continue in this presentation.
Thanks, Dario. So I'm actually going to hand back over to Verna, who's going to give us a little bit of a background to why this trial is important and tell us a little bit about the landscape of early breast cancer treatment for those of us in the audience who may not treat breast cancer on a regular basis. Over to you, Verna.
Thank you. Yeah, thank you very much for joining us. So we are going to talk about this trial that was published last year about the use of adjuvant abemaciclib plus endocrine therapy for hormone receptor-positive epidermal growth factor receptor negative early high-risk breast cancer results for pre-planned monarchE overall survival interim analysis, including a 5-year efficacy outcomes. Next slide. So let's catch up on how to manage ER/PR positive breast cancer. So for many years, what we've known is that we have a mastectomy or lumpectomy with either sentinel node biopsy or axillary lymph node dissection, followed by chemotherapy or based on the pathological features and oncotype scores, and then radiation if indicated, followed by endocrine therapy, which was an AI aromatase inhibitor or tamoxifen with or without ovarian suppression for premenopausal women, and bisphosphonates as well. And over the time, this paradigm has changed and we thought we could do better by intensifying treatment and improving outcomes. So based on a lot of clinical trials that went on, next slide, we came up with the aromatase inhibitors versus tamoxifen in early breast cancer, looking at a meta-analysis of randomized trials. And we found there was a significant 10-year gain in terms of recurrence with advantage of AIs of statistically significant of 3.6% 10-year gain. And in terms of survival, we realized that 1 in 5 women with early breast cancer will recur in 10 years. So that's something we all should remember. And that was the whole idea of all these trials. Then we also know that up to 1 in 8 women with early breast cancer would die within 10 years. So what can we do to improve this? So again, we realized that there was a 2.2% 10-year gain with aromatase inhibitor over tamoxifen. So that became the standard for postmenopausal or with ovarian suppression. There was a little bit of back and forth about what was superior, but in the end, that was the recommendation in the guidelines. Then we have the monarchE study design, which looked at HER2 negative, hormone receptor positive, node positive, high risk, early breast cancer. There were other criteria: men or women, post-menopausal, with or without adjuvant chemotherapy, and no metastatic disease. The first cohort was high-based. They had either more than 10 axillary lymph nodes, or 1 to 2 lymph nodes in at least one of the following, either grade 3 disease or a tumor more than 5 cm. The other cohort was based on Ki-67 levels, either 1 to 3 axillary lymph nodes, a centrally tested Ki-67 greater than 20% or equal to, no grade 3, and tumor size could not be larger than 5 cm. The intent to treat includes both of these 2 cohorts. We had 5,637 patients with a ratio of 1:1, stratified into prior chemotherapy, menopausal status, and the different regions. And the patient on A had endocrine therapy and abemaciclib of 150 milligrams BD, and then B had the endocrine therapy standard of care only. And this patient had this treatment for 2 years, followed by a follow-up period, okay, within 3 to 18 years. The primary objective was invasive disease-free survival, and the secondary objectives were invasive disease-free survival with a high Ki-67 populations, distant relapse-free survival, overall survival, safety, and patient-reported outcomes, what we're looking at. Next slide. So the key questions regarding trial methods: is the control arm appropriate? What is the primary endpoint? Is the population representative of the real-world population that might be treated? Is the study powered to detect a clinically meaningful difference in the endpoints of the trial? Is there informative censoring in this study? Next slide.
Thanks, Verna. So
Yes.
I'm going to take us through kind of analyzing some of these questions listed on the prior page. And so one of the things that we often think a lot about here at CSO when we're analyzing trials is, is the control arm appropriate? And what common pitfalls do you really need to look for when you're analyzing the control arm? So here are some examples. Using a control arm that is already proven to be inferior in a prior randomized trial would obviously be a pitfall. Not allowing an effective drug in the control arm, or using a placebo or ineffective drug instead of an active or effective comparator that already has good evidence. So with those thoughts in mind, what is the control arm of monarchE, and is it appropriate? And I think here it really is. So they have chosen appropriate standard of care endocrine therapy with either an aromatase inhibitor or tamoxifen, plus or minus GnRH, depending on the menopausal status. And I also quite liked how they used chemotherapy as a stratification factor. And I wanted to highlight that only about 5% of the patients on this study did not have chemotherapy. So we are selecting a population who are really high risk, who most clinicians in real-world practice would think need chemotherapy, but also to recognize, as sometimes in discussions, I've heard patients and clinicians say, well, this patient isn't fit for chemotherapy. Maybe we can skip chemotherapy and just give them adjuvant endocrine therapy with abemaciclib. That's really not what this trial was designed to do. So I think that's important to keep in mind as well. So the next thing to think about is the chosen endpoint appropriate? And we talked a little bit earlier, as Verna introduced, that the primary endpoint for this study was invasive disease-free survival, with secondary endpoints of distant disease-free survival, overall survival, and quality of life. And I just wanted to take a moment to remind everybody that there is no proven surrogacy for breast cancer between IDFS and overall survival, with the exception of patients with early HER2-positive breast cancer, as illustrated by the lovely paper in Lancet Oncology several years ago now in the insert there. And so, we have to ask ourselves and ask our patients, in the absence of surrogacy, knowing that IDFS does not necessarily predict overall survival, does IDFS have independent value for patients? And I think that's a question that we still need to work with patients to better understand. So what is the justification for using a surrogate endpoint? I think Dario already gave us some important thoughts there, and I just wanted to bring us back to studies from several decades ago now that we're probably familiar with, such as the ATTACK trial. So this is one of the early studies that tried to evaluate whether anastrozole was superior to tamoxifen in terms of preventing disease recurrence for patients. And we've got two panels here, recurrence and distant recurrence. And we can see that in each of those, there was a reduction in the risk of recurrence or distant recurrence from the use of anastrozole. But neither of these, or this study as a whole, did not prove overall survival benefit. And so it was not until we had this 10-year survival meta-analysis with numerous other studies included that we really were able to demonstrate this overall survival gain. And so the argument has been made, if we wait and we don't adopt these abemaciclibs and other CDK4/6 inhibitors early, we might be missing the opportunity to provide survival benefit for patients. But in truth, we don't know yet if there will be any survival gains from these drugs. So the next thing I wanted to touch on is we always need to ask ourselves, is the trial representative of the patients in the real world in whom we might give this treatment to? And so you're going to have to look at this across quite a number of subgroups. And obviously in this presentation today, we don't have time to go into all of them, but I just wanted to highlight age as a potential example that we can analyze. So you can see here that in the study, about 15% of patients were over the age of 65. And if we compare that to the population of patients with breast cancer in the world, so this is based on GlobalCan data, 35% of patients with breast cancer are over the age of 35. So, compared to the entire world population of breast cancer, this is a selective group with less representation of older women. Now, that may be very appropriate because it may be that the biology for younger patients is more aggressive, and that might be part of what we're seeing. In the insert here, they've given us some nice data stratifying outcomes by age. And what I really wanted to point out here is the fact that this is one of the few studies where they've really given us nice information, not only on the relative benefits by subgroup, but also on the absolute benefits. And so the objectives of these journal clubs are not only to point out flaws in trials, but also to highlight things that have been done really well. And I think this is a really important and positive thing, that we can tell the magnitude of benefit in both of these subgroups from an absolute perspective. But what I wanted to also highlight is that women over 65 have a lot of competing risks, and those things need to factor into our decision making. And of course, every individual needs to have their case evaluated, and we should not treat or not treat simply based on age. But we also need to acknowledge that in older patients, the competing risks of mortality from other causes increase significantly. And you can see here data from the Netherlands, where, important to understand, this is not selected just for high-risk patients, but we can see that as we get older, patient population 75 to 80 and then over 80, the risk of dying from other causes is actually much higher than the risk of dying from breast cancer. And so that needs to be factored into these informed discussions that we have with patients as we try and help guide them through making an appropriate decision for their case. So I wanted to shift now a little bit to look at the design stage of trials and what we can really try and understand from study protocols and what's written in the methods about the statistics. And one thing that I think is really important is that we need to be designing trials to detect meaningful differences. But before we can even know if we're doing that, we have to figure out if we can even determine what the study was designed to predict. And so this is the excerpt from the trial protocol and the papers regarding how the powering was designed and the statistics were designed for abemaciclib. And you can see that we have clear understanding of the hazard ratio, the relative improvements that we're looking to detect. But we can't actually figure out what the absolute difference the trial is powered to detect from based just on the trial protocol and what is written in the methods. And I think this is a limitation that, we as a group need to try and push towards having a better understanding of what the absolute benefits that they're trying to detect are. Now, you can do some sort of back of the envelope calculations once the trial has read out to try and figure out what they were initially designing to try and detect. And if we do that based on the statistical sample size for this study, which was over 5,500 patients, it looks like they were designing this trial to detect an IDFS difference of about 60 patients among the control and intervention arms among these 5,500 patients. So, that's not a lot of difference. And that would be what we consider a success. That is what the trial was planning to detect. So we have to ask, is that clinically meaningful for patients and health systems when we factor in these issues of cost and toxicity? And to just put in perspective, in breast cancer, we are designing trials that are far larger in the adjuvant setting than any other subtype of cancer. So this is just a little bit of work looking at FDA approvals in the adjuvant and neoadjuvant setting over the last 13 years. There's been 32 approvals with the average sample size being about 1,200, but you can see that for the breast studies, the average sample size nears 3,000, whereas for all other cancer subtypes, we're talking about roughly 650 patients. So we are enrolling very large numbers of patients to these trials. So when we're looking at the results, I think this is another very important thing that we need to critically analyze, and that is the question of whether there is informative censoring. In the insert here, these are the most recent data for this abemaciclib trial published in JCO earlier this year. But I wanted to highlight that you cannot actually figure out what the censoring rates are in this insert. So in order to walk us through what the censoring might be in this trial, I've gone back to the publication in Lancet Oncology, which was a little bit earlier. And based on the numbers in the life tables, you can see that they've presented the number at risk and the number censored. And you can use that to calculate what the approximate number of patients censored at each of these time points is. And so I've put that in the table there for you to have a look at. And you can see that there is a bit of a difference. I would not say it is huge, but in general, we are seeing slightly higher rates of censoring in the intervention arm than in the control arm. Now, the challenge is you can't really figure out why patients were censored. Were they censored because they were enrolled late and the trial has run its time and the analysis is happening and they're still being followed up, but they haven't had an event? Or were they censored because they dropped out, and for what reason? And this is a bit of a challenge when we come to interpret trials. This is the overall survival data where you can see a similar pattern that censoring is slightly higher in the intervention arm at roughly all of the time points listed there. So what does that mean? What is the actual implication? So you can run sensitivity analyses, and I would encourage everybody to look up this paper in Lancet Oncology in response to the initial publication, where they've performed the following. You can see on one side, we have the analysis for IDFS without adjustment. And then on the panel B, we have an analysis with an adjustment. And that adjustment is that they make the assumption that all of these extra censored patients actually had an event that was not picked up. Now, that's obviously one extreme, and I think it's unrealistic to assume that everybody who was lost to follow-up or censored actually had an event. But you can see if you do make that assumption that this trial shows no statistically significant difference between the two arms. In reality, I think it probably lies somewhere between the without adjustment and with adjustment panels, but the message being that censoring is a risk for overestimating the benefits that a drug may provide. So even though I mentioned that you cannot really tell from those life tables why patients may have been censored, you can look at these flow diagrams to try and figure out why patients might have dropped out of the trial or discontinued their medications early. And so two things I think are important to look at here are the number of patients withdrawing or discontinuing treatment, I should say, for adverse events, and the number that are withdrawing or stopping their treatment for other reasons, such as patient decision or loss to follow-up. And in terms of adverse events, you can see that 1 in 15 women found this medication to be intolerable to the point where they had to discontinue it early. That's compared to only 30 people in the control arm. Now, in the intervention arm, we also see a high number of patients stopping for personal decisions, but that is also relatively high and similar in numbers in the control arm. So I wanted to shift now to just spend a moment talking about how we actually communicate results to patients and also within the media. And this is a really important concept of absolute versus relative benefits that I'm sure many of you are familiar with, but perhaps for those who are slightly less, I wanted to put up this initial quote from Lilly when they released the press release for this study. And they state that the risk of developing invasive disease was reduced by 33% from this intervention. And I think any patient who reads that is going to think that this drug is offering a very large magnitude of benefit. But we need to remember that we should always be speaking to our patients when we can in terms of absolute benefit, because as seen in the example here, relative risk reductions are very confusing. If you have a drug that reduces the risk of recurrence from 2% to 1%, that's a 50% relative risk reduction, but an absolute risk reduction of only 1%. I would like to again highlight that in this trial, throughout the manuscripts that have been published, they've actually done an excellent job of reporting the absolute benefits. So again, we want to highlight things that are done well, and I think that was done very well in this trial. Another thing that I think is important that maybe we don't spend as much time thinking or looking about when we're reading about trial reports is what was the post-protocol therapy. So this is often not mandated in clinical trials, but it is very helpful when it is reported. And in this specific trial, patients who would have progressed or had a disease recurrence and gone on to have metastatic disease, we would expect most of them, if we were treating them according to current guidelines, to receive a CDK4/6 inhibitor in the metastatic setting. And that's based on a number of studies listed there that have shown survival benefit, or at least large magnitudes of benefit if it did not meet statistical significance. So we have to ask ourselves, in this study, where were most patients recruited? And most patients came from China, Brazil, and Mexico. We know that the accessibility of CDK4/6 inhibitors in the metastatic setting in these jurisdictions is relatively limited. We also don't yet know what post-protocol therapy was. Did patients who eventually progressed and had metastatic recurrence, were they offered these medications or could they access them? And if not, how is this going to impact on the eventual overall survival data that we have? So I wanted to take a moment now to reflect a little bit on what's important to patients in treatment decisions. And I think Michelle's going to be able to give us her perspective here as a patient advocate. But some important things that we often maybe don't think about as much as we need to are things like the treatment-related processes and the time toxicity, the risks to the patient, the quality of life, and the costs of the treatment. So I'll offer Michelle a moment here just to make some comments on the patient perspective.
Sure. Yeah. Well, I mean, from the patient perspective, it varies depending on the setting, right? And in the early stage versus in a metastatic stage. But I mean, for sure, one of the most important things to patients are, is this going to help me live longer? In the adjuvant setting, I think we're a little more ready to accept toxicity and, for in the short term, for the prospect of an actual cure. But, I don't know that, when you're talking about the treatment related processes, how is this going to impact your quality of life, or, the number of visits you're going to have, and what are the side effects? I mean, that's really important to patients as well. We already know in hormone receptor positive breast cancer, that it's hard enough to get patients to take their endocrine therapy, let alone taking another drug that causes so much more toxicity. And so, quality of life is important. Nowadays, I mean, when I was treated back in, 15 years ago, cost was not as much of an issue, but today it really is. And the thought of having to take a drug that costs, in the United States, potentially upwards of $15,000 a month, that can really strap a family who has to deal with that. So, these are all things that really matter to patients. And, I'm sort of grateful that I was diagnosed when I was, so that I wasn't confronted with the possibility of having to take a CDK4/6 inhibitor. But in any case, so I'll pass it back to you, Brooke.
Thanks, Michelle. So we wanted to spend a little bit more time diving into the quality of life impacts, because I think this is really important. So I'll hand over to Dario, who's going to walk us through some of the data that was published related to quality of life.
Yeah, thanks. I think now we should really take a look to how we contextualize the efficacy in the context of the quality of life and understand definitely what this drug is providing to patients in terms of benefits in a multidimensional perspective. And here you see one of the publications that was provided by the authors of the monarchE and investigators to understand what was the perception of the treatment from the patient perspective according to established and evidence-based scales for quality of life. In particular, the assessment of the quality of life in this trial was pretty reliable because it was a secondary key endpoint. So really there was interest, of course, to understand how patients' perception, was pursued in this trial. And also because the sample size is pretty large and many patients really they can compile, they fill the quality of life questionnaire, we have some data that are reliable and they can show definitely what was the experience of the drug in the clinical trial. Next slide. So in particular, as you see, the quality of life overall with the utilization of the general health scale was overall similar with the use of the endocrine treatment and with the abemaciclib, with the, throughout the follow-up from the treatment initiation to the last follow-up. Patients were asked to fill the questionnaire for quality of life throughout the clinical trial participation. There was up to 24 months of treatments, but there was no post-treatment quality of life, assessment. And at this point, we miss the post-clinical trial experience, but this is very common with the adjuvant clinical trials and overall with the clinical trial. So we don't really have a sense, how this experience with the drug then may impact on the longer term in the quality of life. But in general, when taking the drug, there was a slight increase in the toxicity, especially initially in the first trimester, that is associated with a plateau of the toxicity. But then, the quality of life assessment was pretty similar. And in particular, the report at any end and any time point, it was similar. It was over 90% of the patients reporting the quality of life. So this was really something that investigators wanted to be reported in the clinical trial. Next. So of course, when we assess the clinical trial, usually we assess the quality of life clinical trial during the treatment. That's again, we don't really have a clear sense of what's happening after that. And we can report this in a different way. In particular, some patients the quality of life may be reported as an average score. Some clinical trial reported as time to quality of life detriment. So of course, we have many metrics. And the real problem now when we assess the quality of life is that we don't really know how to compare with other interventions, and then what is the best, quality of life metric that we should utilize. And in fact, there is an entire working group from ERTCs called CISAQUAL that's working specifically on that, because now we report this data, but honestly, we don't necessarily know how to contextualize, how to interpret several metrics at this point. Here, as you see, we see, some of the, the clinical trial reporting, the patients experiencing toxicity during the interventions, but then again, we really miss something that's happening in the post-protocol phase. Next slide. So in particular, something that we should also contextualize in terms of quality of life is how the drug is really able to reduce the risk of distant recurrence. As you know, when the cancer recurs in a distant site, usually disease uncurable. And so there is like a big switch from what is the curable setting to the incurable that is not necessarily all the invasive disease-free survival event, but is totally for the distant disease recurrence. And in particular, in the monarchE, it was demonstrated that up to 60% of the event of recurrence were distant recurrence. And this kind of recurrence was definitely reduced in the distant sites of about half with the use of the abemaciclib in the setting of the adjuvant treatment. So it is like we have some data in the literature that shows that probably distant recurrence may correlate better with overall survival in the luminal-like breast cancer. And so probably that's the endpoint that we should utilize, but it's pretty intuitive that this is the one, of course, making the big difference, the big switch for the patients, moving from the curative to non-curative patients. And this may have, of course, an impact on quality of life. Because one thing is definitely to take a drug for the curative setting for a specified period. Another thing is definitely to take up to progression for longer and prolonged period. And of course, the impact on quality of life for prolonged treatments may be definitely more challenging and higher. And at this point, we don't really know what is the impact on quality of life for patients recurring, but in fact, assessing the quality of life also in the post-protocol phase may really inform on this aspect. They may, of course, give us a more comprehensive and a better idea of what is the patient's experience overall and throughout the journey, and not only in a specific phase of the experience. Next one. We should also contextualize, of course, this drug as it pertains to toxicity, because toxicity profile of abemaciclib in this setting is not trivial. In particular, there is 46% of patients having a grade 3 or higher adverse event. It does mean moderate to severe adverse events, and there is a small proportion below 1%, but more than the control arm that experience toxic death. So they can really experience fatal outcomes with these drugs. The most common toxicity that was experienced by patients in this clinical trial was usually gastrointestinal toxicity, nausea, vomit, and diarrhea, and of course some cytopenia that is usually laboratory-based, and in this specific trial never resulted in the febrile neutropenia or infections. So it was definitely something monitored with the labs. But totally, the plateau at the first trimester that also has impact on the quality of life and on the diarrhea-specific quality of life scales is non-trivial for patients, because when you find those, in first trimester where most of these toxicity occur in the worst cases, then patients really have a bad experience with the utilization of these drugs. And you see that most 3 out of 4 of the patients had diarrhea. Some of them is low grade but persistent. It does mean they have a complete change in the habits for the bowel movements. And also around 10%, it's 7.6 to 10%, they have a grade 3 or more diarrhea. That does mean, of course, the quality of life is highly impacted. Next slide. So when we want really to understand in a value matrix what is the benefit of adjuvant abemaciclib, utilizing only the efficacy data in terms of improvement of the disease-free survival, we can use some value framework, including and specifically the ESMO magnitude or clinical benefit scale. For the adjuvant setting, the MCBS at this point is shaped in a way that we capture only the efficacy data to understand how the drug can reduce the risk of recurrence, including the distant recurrence. That's the big change for patients. And of course, how this translates in an overall survival benefit. So based on the report of the DFS data that we have for the adjuvant abemaciclib, you see that now abemaciclib is scored with a high value drug, as a priority drug in the adjuvant setting because of the DFS improvement with a hazard ratio that is below 0.65. In particular, the hazard ratio here should be considered as the lower boundary of the confidence interval. It's a very technical nuance, but at this point, we should consider the 0.599 to score according to the MCBS, because it's the MCBS rule to consider that specific number. Of course, as the data of overall survival mature, we can understand if the MCBS score will remain the same, if the promise of DFS improvement will translate in an overall survival improvement, then you definitely get the A. If it's more than 5% improvement of the overall survival at more than 3 years, but then if there is not such an improvement, or even you don't demonstrate any overall survival improvement, or you have a detriment in the improvement, and we hope it's not happening, there is a downgrade of the score. And so at this point, we don't know how the data will mature, because in the last report of the monarchE clinical trial, it has not been demonstrated any change in the overall survival overall. It's still immature, but we don't have any of these data. Next slide. So when we have to implement, in the clinical practice and also to make decisions to uptake and reimburse drugs like new adjuvant agents, of course, the consideration to take into account are multiple. And it's not only the efficacy, of course, because in the real practice and in the context of reimbursements, when you have to dispose and allocate the resources for the treatment of cancer overall, you need to consider several questions. And in particular, one is how the population is impacted, how the patient's experience is impacted in terms of quality of life, and so of the toxicity in terms of efficacy, how this improves population health, and also of the cost. And usually it's a composite matrix in the trade-off of these elements that really make us the decision to adopt in the clinical practice, but also to adopt at the reimbursement level to decide if to cover or not at several levels. I should say the cost usually is a driver for health system budgeting in high-income countries because usually high-income countries have universal health coverage. So the decision, of course, to reimburse or not a drug may be in part driven by the cost of the drug itself. But when you move a low and middle income country in which there may not be universal healthcare for cancer, usually this cost weighs on the patients themselves. And sometimes this is so unacceptable that most of these patients, they will never access to any of these drugs because they just cannot afford usually. Next slide. And here we want to show you some exercise. It's like an HTA-like exercise, but it's not a formal HTA. It's really something that we produced with Dr. Kia from Canada, and really want to understand what is in Canada. In the context of Canada, high-income country, very strong universal healthcare coverage and budgeting for the cancer treatment. What is the impact to approve a drug based on a preliminary DFS results, so on surrogate endpoints, a new drug. And in particular, the example that we did here is not the CDK4/6, but it's an older decision. There was when data from ATA clinical trial of Big 198 comparing aromatase inhibitors and tamoxifen came with the pretty reliable data on DFS improvement, especially in the postmenopausal women, but not over survival data that actually have come very, very later on, for who is a breast cancer oncologist. And you see that just making an estimate for 1 year, that is 2023, with an estimated number of over 29,000 new breast cancer cases in Canada per year, of which 65% of them 70% are in the curable setting, and most of them will be ER positive, so they will be eligible for the interventions with endocrine treatment. You see that at the end, with the data that we have, you can reduce around 1,400 relapses prevented with the use of a new drug as aromatase inhibitors over tamoxifen. But the problem when you make these kind of decisions is that you don't have the overall survival data. So whatever you are recurring, you don't know what's the actual impact on the population health and the overall survival overall. And so when the end of the clinical trial data, the final mature overall survival data come, and you don't have any overall survival benefit, then you know that probably you are overtreated, mistreated some of these patients, and that probably you haven't really provided what it was an appearing benefit for those patients, especially when you have a DFS OS discrepancy. One is improved and the other one is not. You don't really know what does it mean, to reduce those kind of recurrences. Next slide. And the same kind of course of discussion is now undertaken in many HTA bodies. And we just provided some exercise, again, from the Canada perspective, high-income country, to understand how it can be reimbursed, how decisions about the adjuvant CDK4/6 can be taken. And in particular, you see that, we reimburse aromatase inhibitors, for breast cancer in the adjuvant setting with a pretty small DFS benefit, with a number needed to treat that was 1 out of 37. You need to treat 37 patients to get one from recurring from IDFS, and it's almost 2 times more, 1 out of 60 to prevent one distant recurrence of breast cancer. And you see that, of course, the cost consideration at that time for aromatase inhibitors and tamoxifen were definitely in the same magnitude of the cost. It was like around 40 cents per day for tamoxifen, $1.40 US for aromatase inhibitors. So it was not that different. Of course, it was not like a huge budget impact overall. And so this was definitely acceptable also because there was not a huge impact on the health system utilization resources. But when we move in the space of the CDK4/6, you see that patients need more hospitalization. They need more to access the healthcare services, to manage toxicity, and to monitor. In particular, they need usually every month at least And then every 3 months, some CBC, some blood monitoring, they need to be visited. You need to be careful because they're taking an actual chemotherapy drugs that requires really to be monitored in a close way. And also you see the cost for 1 month of treatments is at least 2 orders higher in magnitude. It's around every month, it's around over $5,000 to $6,000 per month. So for 2 years of treatment is, of course, just a huge proportion of this money that have to be invested with a cost effectiveness threshold that is not very favorable in many other countries in the world. Here, the cost to prevent one DFS event with CDK4/6 in the adjuvant setting, that's abemaciclib, is around 1.7 million. That for many countries is definitely an unacceptable threshold for cost effectiveness, decisions with a lot of impact on the health system. And of course, when you make this decision with a drug that definitely improves much more than the old endocrine treatment, the risk to recur of the cancer is definitely reduced in a significant way with an NNT that is 1 to 13, 1 to 15. So it's a tangible benefit perhaps for patients with the data that we have, but with such a high cost, the threshold is definitely controversial because you have something that may help patients, of course, with all the implications of this kind of utilization, but at the same time, the cost is so high that this kind of consideration may really affect the trade-off. And so some countries cannot or may not just afford to reimburse these drugs. Next slide.
Thanks, Dario. So we're going to hand back over to Verna, who's going to give us a little bit of a wrap up on the perspective of these medications in low and middle income countries, which is, I think, a really important perspective from a global health context.
Thank you, everybody. So I'm just going to look at the situation in many African countries that might translate it to other low to middle income countries. I did a short survey of the availability of CDK4 inhibitors, and it's free in Rwanda. It's a donation. In Kenya, it's on the health insurance. In South Africa, in the public sector as compassionate use. And in Mozambique, it was just rolled out in compassionate use by Max Foundation. And most of it actually is palbociclib, except for Kenya that has the rest of it. Out of pocket in Nigeria, they have ribociclib and palbociclib. It's a subsidized rate of $300 a month. In Zimbabwe, it's out of pocket. In Ghana, it's mainly palbo, occasionally ribociclib. And Rwanda, in the private care, you have to pay for it. But it's not available in other countries like Ethiopia, Tanzania, Somaliland, and other countries. So just to give you the picture, because we are a little bit far behind in what is accessible to us for many reasons. Please go next. All right, so let's look at, we haven't had that many economic evaluations of CDK inhibitors in developing countries. And most of the evidence that we have right now is mostly for the metastatic setting in high income countries. There was one study that was done and published last year in America. And in the metastatic setting, they thought it was not cost effective at 100,000 per DALI gained. Another study looked at the cost effectiveness of varied between 24,000 in Spain to almost 200,000 in USA. And the mean incremental cost effectiveness variation ratio varied across different countries from 1,800 in Spain to 830 in USA, but this was considered cost effective. In another study, however, it also thought looking at abemaciclib by itself, abemaciclib added to standard therapy was considered cost effective. However, the differences in results between the therapies were not statistically significant. So that's also another big problem. So they tell us all the drugs are actually almost equivalent in disease-free and overall survival. And yet when it comes to certain points, they tell us to choose one over the other. So that is still very confusing and to take some time to really clear this up over the period of time. And this, I'm talking really right now about metastatic setting, but this could eventually roll into the early breast cancer trials. Maybe the duration in early breast cancer might be shorter than metastatic, but it's not for us to say until the evidence supports this. There was another study that looked at the current price, adding ribociclib to endocrine therapy actually was not cost effective in Singapore at the cost of which it is. We have to know right now that calculating DALIs actually depends on so many issues and they are specific per country. It looks at the payer perspective, the societal perspective, and the willingness to pay. So you might not really match what America is able to pay to lower to middle income countries. So a lot goes into it, and that just goes to solidarize what we say, that these things have to be repeated in countries like ours. We are the real world to see how effective they are. I think somebody just posted a note that Max Foundation is rolling abemaciclib out in other countries as well. So I think this is good to something that we can look at. Next slide. So this is a slide that again just gives you the different cost effectiveness in the again in the metastatic setting. This was an application that was made to the WHO Essential Medical List from ISMO, and you can see that most of the drugs actually here may or may not be cost effective depending on the country. Just to support what I said earlier and the different studies to see this, and most like we could see ribociclib in particular didn't seem to be cost effective, you know, for this indication. Unfortunately, most of our countries do have ribociclib. Now we are trying to roll out abemaciclib, but you can see there's no data really there that supports the cost effectiveness of abemaciclib, even in these countries either. So we are like, you know, walking in the dark. Next slide. So again, like as Dario earlier said, it's only countries like Sweden, Netherlands, and UK that incorporate concerns of fair distribution of health. But in other countries, they really look at the cost effectiveness of the drug and then how much it will benefit the society. So higher cost of drugs without anchoring how well these drugs actually work is driving up overall healthcare costs and spiraling prices that lead directly to reduced access and higher out-of-cost patient cost for all patients. So we should remember it's not just the cost of the drug, it's also the cost of the health to the health system that we all seem to forget about, especially in countries like ours that we have a high out-of-pocket and payment for our patients. So we really need to have these trials repeated in our countries, to low middle income countries, to weigh out all the options, because as you know, our health spending budgets are less than 5 to 10% of our overall health budgets and GDPs. So it might really cause a lot of problems and actually cause negative gains in our systems where we have less access to treatment. So thank you very much.
Thanks, Verna, for providing that really important perspective from a global health context. So that brings us to the end of the slides that we prepared. Hopefully that was educational for everybody, and we're really happy to take any questions if you had any comments or wanted to have any discussion. Please, you can either put it in the chat or you can raise your hand.
Some discussion in the chat a little bit on how HTA bodies take these decisions, but I think there are also some responses, answers about how regulatory agencies work and how HTA bodies make these decisions.
Yeah, so I mean, I guess maybe one of the points to take out of that is that, you know, HTA assessment is complicated, and one of the challenges, I think, for many low and middle income countries, as Verna's alluded to, is that they may not have the systems and processes in place to make their own HTA assessments regarding some of these medications, but equally that each country will come to a different conclusion due to the unique circumstances in which they practice. So this is obviously a challenge for many countries. The absence of an HTA body to perform this work is a real challenge for a lot of places.
And then I think there was one question on the Max Foundation. I'm sure you have like experience, of course, in the access program of the Max, and perhaps someone wrote that they have interest to introduce CDK4/6 in some African countries, including Kenya. Do you have any experience?
Yes, so right now,
knowledge?
Yes, I do. They actually just rolled it out in Mozambique. And so we are trying to see, I made a personal appeal to see if it can be rolled out in Ghana as well, for the metastatic setting, not really for the early stage. So I'm hoping that they will listen to us, because it's for low to middle income countries. So I hope that it's for low income countries right now, but we are pushing to see, but in reality, most of us really are low income countries. So we are trying to really push for them to consider us as well. So I'll be surprised that they are in Kenya. Kenya has a lot of lobbying power, so I'm not surprised that they are getting it. But I think it's good that this will happen. Yes. I think Peter raised his hand.
Like another question. Oh, we have one hand raised.
Yeah.
Good evening. This is Peter Oiro from Kenya, medical oncologist from the University of Nairobi. It's true, Max Foundation has been very helpful to us through the same access program that we get a number of tyrosine kinase inhibitors like imatinib, dasatinib, ponatinib, and Sutent, that is sunitinib, axitinib. So they've just added abemaciclib, and we have already worked out the modalities of providing abemaciclib to in the metastatic setting to Kenyan breast cancer patients. So this is going to go a long way because despite the fact that the National Hospital Insurance Fund has been providing some partial financial assistance to patients, most patients do not get these drugs continuously because this social program only caters for 6 cycles in a year. So that is 6 months in a year. So the rest of the 6 months, you find patients are left without access to these drugs, and it costs about that's 100,000 Kenya shillings. That's almost 1,000 USD to provide like palbociclib to a Kenyan woman all the in 1 month. So that is out of reach of most Kenyans. So the presence of Mark's Foundation in the country has been a blessing to us, and we hope that this abemaciclib is going to help a number of breast cancer patients. Thank you very much.
I also say there is a lot of differential pricing. So in China, 1 month of abemaciclib is $800 versus $81,000 in the UK. So there's a lot of, so the whole thing is also about the cost of the drug and where you live. And I think in terms of the disparities, I think they really have to look at that, because even $800 is not affordable to many in low to middle income countries. So we really need to sit down and really look at all of this. And that goes into the critical appraisal of the benefits before we start using it in early breast cancer.
Thanks, Verna. Any other questions? Otherwise, we're about to come to the top of the hour. I see some interesting discussion in the chat related to the challenges of these expensive drugs coming into guidelines. I think that's a really topical and challenging issue. And as Michelle's written, communication is critical. I think that's really true. These are difficult discussions. Even in high income countries where we potentially have access to these drugs, they're difficult discussions. And I think all the more when you're asking for a patient to potentially pay out of pocket. And anytime something's in a guideline, I think we as clinicians, or at least I know I feel some obligation to prescribe it and to use it. And I think patients often feel if it's in a guideline, then it should be given. And so I think it's also important to remember that guidelines are created by individuals who may have different perspectives, and it can be a real challenge to reconcile your perspective with the guideline perspective with what the patient wants. And so it's really comes down to that core discussion between you and the patient, if you're a clinician, about what the value is for that individual. But I think that's a really important point related to the guidelines that's been written in there.
There's a comment about IDFS and DFS.
Oh, yeah. So the question is, what is the difference between IDFS and DFS? Why they consider IDFS in the study instead of DFS? So IDFS includes invasive disease-free. So the cancer recurrence has to be a true invasive cancer, whereas disease-free recurrence in some studies will also include precancerous changes such as DCIS. And so there are subtle differences in terms of the patient inclusion for that reason as to what an event would be.
So Brooke, can you just comment on why distant disease-free survival is not more important than invasive disease-free survival? Because I do think disease-free survival is an important endpoint from a patient perspective, because you're living longer without invasive disease. That's a tangible benefit. But it seems to me that distant disease-free survival would be far more relevant, and a far more relevant endpoint.
I think you make an excellent point, Michelle. And, I personally think that DDFS, or the distant disease-free survival, is the metric that I have a lot more interest in seeing a large magnitude of benefit for, because If you have an IDFS event, then there is a possibility that you could do a further local surgery and still cure that patient. So I think if you look at IDFS as the endpoint, you risk maybe diluting some of the survival benefits. But on the other hand, we can't ignore that for some patients, having a recurrent lesion in the breast is a very traumatic event. And so depending on the patient, they may place a lot of value in not having to go through another surgery, not having to be reconsidered for radiation. So there are different ways of looking at this. And I think this is where perhaps we have not adequately evaluated what patient perspectives are on the optimal endpoint for early breast cancer trials. And I do hope that more research will be done in that space in the near future. So I think that's probably all we have time for today. I just wanted to say a big thank you to all the speakers who joined us today, but most importantly to everyone in the audience who took time out of their day to learn about Common Sense Oncology and work through this important clinical trial in breast cancer for us. Thank you again.